think we have to start with a short slide. It's my pleasure to start our next session, and I welcome all of you, and I hope that we all enjoy this section. And I will leave the phone to our colleague, Dr. He will present our first.
That's fantastic. Thank you.
Good morning. The second day of the conference, we are happy to present Dr. Arun Chandri. He is MD FRCB Edinburgh, consultant acute physician, Manuel Hospital and Medical School, Dundee, Scotland. He is a Scottish Patient Safety Fellow. He graduated from Calcutta, India in 1989, came to UK in 1995, got MRCB in 1996, worked in cardiology from 1996 to 2003, joined in acute medicine in 2003 as a registrar, consultant since 2007. Honorary senior lecturer of Dundee University, patient safety fellow, and he is enjoying teaching and is passion in quality and safety. Dr. Chandri.
Thank you, Dr. Thank you, Dr. Sari. It's my pleasure to come and talk to you about.
And he will talk today about the acute medical problem in pregnancy. I think it is a lecture good for a lot of doctors. Welcome.
Thank you so much, Dr. Sari. It's my honor to speak to you about the acute medical problems in pregnancy. I have to admit that I'm not an obstetric physician. I'm an acute physician, and my interest is acute medical problems in pregnancy. Why I'm interested? There's no option, because 7 out of 1,000 admissions are pregnant. So we do see around 16,000 patients in our acute medical unit. So around 112 patients in a year are pregnant. And out of them, around 10 to 11 patients, they are critically unwell. And there is a potential that 4 out of 11 patients can die. And what are the challenges of acute medical problem in pregnancy? Because I'm going to discuss in details all the points. We'll deal with 2 patients, mother and fetus. We don't recognize acute medical problems in pregnancy early, and we still do not know how all the investigations we do for acute medical problems have got effect on the fetus. And there are certain situations, certain presentations in pregnancy actually present in a different way. It's a very difficult diagnostic problem. Management, acute medical problem in pregnancy, this is not evidence-based, this is not randomized clinical trial on this. And there are lots of prescribing issues. The drug effect on fetus and on lactating mothers. Now, if you look into the maternal mortality rate, and in the perspective Jordan as well, that the maternal mortality rate is the annual number of female deaths per 100,000 live birth. Now, if you look into the 2010 data, there's a total death of 287,000 in that year, and out of that, 1,000 maternal mortality in Somalia, India 200, Jordan 63, and UK currently is 12. Now, what are the leading causes of maternal mortality? Thromboembolism on the top of the list, 29%. Severe sepsis, 13%. And severe sepsis now mostly the very common is genital sepsis and also streptococcal sore throat giving rise to severe sepsis. Stroke, cardiac conditions like all the arrhythmias, pericardial cardiomyopathy, and then hypertension that includes preeclampsia and eclampsia. Now, if you talk about two patients, that mother and fetus, because we know that any disease, the pre-existing or new condition, can actually alter the pregnancy. Pregnancy can alter the disease, and disease may directly affect the fetus, and all the investigation and treatment may affect the fetus as well. Late recognition, why is that? That we have got all the problems with the physiological changes of pregnancy. We think these are all physiological changes. We need to understand about all the normal physiological changes. The blood pressure falls in early pregnancy by 10 by 5. And at term, it comes back to normal. So it's very important to remember that. Heart rate increased by 10 to 15 beats per minute. Circulating volume goes up by 50%. So a normal blood pressure in any acute medical condition in pregnancy is not a reassuring sign. And tachycardia, heart rate more than 90 or 100, is definitely abnormal in pregnancy. Tachypnea is also unusual. So that is the main reason that we always think the patient is tachycardic, tachypnea is good due to pregnancy. This is not, could be an acute medical problem. The investigation in pregnancy, again, these are the areas that you always, sometimes the junior doctors ask me, shall you do a chest x-ray? Shall you do a CTPA? Shall you do a VQ scan? So it's very important that the risk to the mother is saying whether pregnant or not pregnant. Is the perception of fetal risk is much higher than the actual risk. Now, we have to remember that a missed or delayed diagnosis can pose a greater risk. So you must do investigation. The ultrasound and of course MRI is safe for baby and fetus. And there's not enough data about how much is actually very harmful for the fetus, but some data that less than 5 rads throughout the pregnancy is safe. Now if you do a chest x-ray, it is a few days worth of background radiation. We all get. So it's around 0.02 millirad. If you do a CT abdomen, it gives you 3.5 rads exposure to the fetus. If you do CT chest, 1 rad. If you do CTPA, we don't do CTPA in young women because the chance of risk of breast cancer in the future. But again, at radiation-wise, around 3 rad. Perfusion scan in the lungs, you do it for pulmonary embolism, and the fetal exposure is around 50 millirads. But again, the important point to remember that you must do investigation. And whenever there is any confusion, discuss with the radiologist and explain the risk to mother, because they are very anxious. Now, difficult diagnosis, as we are discussing with an atypical presentation, this is a report from the confidential inquiry into maternal child death in UK, that is 2007. They highlighted 2 points, that the especially ectopic pregnancy can present with gastrointestinal disease, the diarrhea, vomiting, and also it could be due to, it can cause fainting. So we need to remember that ectopic pregnancy can present with GI problems and fainting. Now, medications in pregnancy, we heard from Dr. Stone that there are antiepileptics, and I'm just going to discuss a few important points. There is a limited data on medication safety. What I do avoid in our acute medical unit, that the 3rd trimester I do not use any non-steroidal anti-inflammatory drug because it can cause premature closure of patent of ductus arteriosus. I avoid its inhibitor and ARB because in the 1st trimester it causes CVS and CNS malformation, and the 3rd trimester it can cause API of fetus. Glucocorticoids, and we know that it can cause late balance and gestational diabetes and pregnancy-induced hypertension. Whenever there is any confusion, again, discuss with your pharmacist. Now, management of acute medical problems, again, there is not enough evidence. Most practices are based on animal models or expert opinion. And a lot of physicians who do not have enough experience of identifying, investigating, and managing those patients with pregnancy. Just going through a few cases very quickly. That's my first case, and I was a registrar in actually 2000. That was in 1996, and it was a Sunday. lunchtime, I got a phone call from my consultant obstetrician, and said, I need your opinion about a 38 weeks primary gravida, admitted with palpitation, no chest pain, no pyrexia, breathlessness, or cough. She had history of supraventricular tachycardia, but not on any medication now. Heart rate is 180 per minute regular. Stable hemodynamically, blood pressure is okay, and 12-beat ECG is supraventricular tachycardia. Could you please come and help me out? And I cannot tell you what was going through my mind. I was absolutely like, I never ever managed SVT in pregnancy. I know how to manage in a normal patient that say, but I was thinking, I was got the phone call, I said, okay, I can do carotid massage, I can do Valsalva, but is adenosine safe? Can I give it in pregnancy? Can I cardiovert electrically? And my heart rate was really up. I rang my consultant cardiology colleague, and he was driving, and I said, Orun, let me drive, stop my car. He said, Orun, I never managed as well, but transfer the patient to CCU and try some adenosine. This short-acting drug should be safe. So I said, okay, transfer the patient to CCU. I was so lucky. When patient came to CCU, patient was in sinus rhythm. It's great relief for me. So, but that actually highlighted my weakness. And that is the first time I developed my interest, that I need to know more about acute medical problems, because I was working in a district general hospital. You may not have an obstetric physician in that hospital. Now, when I read that SVT is not uncommon in pregnancy, because you can have SVT, VT, all the arrhythmias. And adenosine is very safe. You can give adenosine 6 milligram and then 12 milligrams exactly the same way you give it to the non-pregnant mother. Electrical cardioversion is safe, so if patient is hemodynamically unstable, give them cardiovert electrically. You can give them, second line of drug is IV metoprolol. I do not prefer to use verapamil because it has a longer half-life and it can cause hypotension. My second case that I got a call for a cardiac arrest, a 36 weeks pregnant lady, and the initial reading was PEA, pulseless electrical activity, and immediately we put them in the left lateral position. Cardiac massage was commenced, intravenous adrenaline, IV fluid, cardiac output back in 2 minutes, transferred to high dependency unit. Actually, the lady was admitted with streptococcal sore throat, and she was not prescribed any antibiotic by GP. Again, in pregnant ladies, you must ask about, most of them, they've got another child and they get streptococcal infection, so mother gets it, and then you must give them antibiotic early so that they don't develop severe sepsis. So, what about collapse in pregnancies? What are the common causes? The cause is hemorrhage, abruptio placentae, rupture or dissection of aneurysm, ectopic pregnancy, pulmonary embolism, amniotic fluid embolism, severe sepsis, and whenever you have for severe sepsis and patient lying supine, you can have less venous return while lying supine. That's why you need to put them left lateral so that more venous return and you can get your cardiac output back early. Now, let's talk a little bit about amniotic fluid embolism. I've never seen any patient in my life, but I'm not an obstetric physician, that this is not uncommon. That patient can present with sudden collapse, severe dyspnea, chest pain, cyanosis. The common during labor or during delivery and up to 48 hours postpartum. And it's very prone to develop DIC, so watch for DIC. And they can develop coma or seizures, and mortality is 10 to 90%. And diagnosis is sometimes it's a clinical diagnosis most of the time, and you can do diagnosis by sample from ET2 or central line for fetal sperms. So very, very, it's a life-threatening condition, so think about it. CPR in pregnancy, as I said, left lateral tilt, and access to thorax is restricted by gravid uterus and pregnant breast, so it's very important that we take a room for it. and always put cannula in the upper limbs because of venous compression by gravid uterus. Always put cannulas in the upper arms. And it's very important to call the team because there are 4 and 5 minutes rule that as soon as the cardiac arrest starts, the time you have to measure the time that how much after 4 minutes you have to start taking the baby out. By 5 minutes, the baby should be out. So it's very, very important, 4 and 5 minutes rule. So team should be ready and you have to take the baby out in the ward, in the medical ward. Third case is, it just happened just 1 month back. 36 weeks pregnancy, admitted for vomiting for the last 3 days, not eating and drinking. And blood gas on air, pH 7.26 and base excess minus 15.4, severe metabolic acidosis. It's very important that we exactly work out the same way we work out metabolic acidosis. It's non-pregnant. So we actually checked the anion gap. And anion gap was 30, so it's a high anion gap acidosis. Creatinine was normal, lactate was normal, salicylate level was normal. There was no concern of methanol or evening glycol poisoning. The blood ketone was very high. So the diagnosis was first in ketosis in pregnancy. And, she had some Indian curries actually and the evening before and then started vomiting. So it was the food poisoning and that caused this particular. And the patient was given IV fluid. Of course, the patient was vomiting. You need saline and also you need, very important thing, to give glucose, 10% glucose. Also was given thiamine injections. And one thing you need to monitor very closely is the potassium and magnesium. Because as soon as you give dextrose, the potassium will move into the cell. And ketone will come out of the urine with potassium. So you have to replace potassium. And so check potassium and magnesium. Control the vomiting and fetal monitoring, monitor ketone. And this patient was fatal within 24 hours and went home. Normal delivery at 39 weeks. So the important thing to remember that exactly the same way you work out metabolic acidosis in a non-pregnant lady, you do the same investigations. Fourth case is 10 weeks. I mean, this case I chose just to demonstrate what we should do if you suspect a pulmonary embolism. So the history was very much suggestive of pulmonary embolism and all the examination normals, ECG sinus tachycardia. Now, if you get shortness of breath, I mean, you should think about all the common conditions which can cause severe anemia, pneumonia, pneumothorax. Don't forget that. This is a very important, rule out very common conditions which can cause breathlessness. Of course, the 6 times higher probability of pulmonary embolism in pregnancy and 16 times higher in preperiod. So when you get a patient, you think about being up to 6 weeks postpartum. And also you can have pulmonary edema. Now, this particular patient, we didn't do D-dimer. Don't do D-dimer, please, in pregnancy. It's not useful to do D-dimer. Chest X-ray, you must do chest X-ray. That's very important again to emphasize. Please do a chest X-ray. Chest X-ray was normal cardiac size. There was no fluid in the lungs. According to guidelines, the next stage should be bilateral venous Doppler of the legs. We did that. There was no clot. And I'm trained in transthoracic echoes. I did an echocardiography. There was no right ventricular strain and normal left ventricular size and function. Then, according to guideline, we have got facility for perfusion scan of the lung. You can only do perfusion scan. You don't have to do ventilation perfusion scan. So we did the perfusion scan. It showed multiple bilateral pulmonary embolism. So diagnosis is confirmed. The question is, how do you manage it? You just give low molecular heparin. That's because it does not cross the placental barrier. But when you give that, please monitor platelet because it can cause heparin-induced thrombocytopenia. Now, warfarin contraindicated because there is a substantial increase in fetal anomalies, mainly the CNS defect, and it can cause fetal bleeding as well. There is no data or new or anticoagulants like rivaroxaban or apixaban, so do not please use it. There's no data yet. Thrombolysis. Can you thrombolize PE in a pregnancy? Yes. case, a patient is hemodynamically unstable and it's confirmed pulmonary embolism by your perfusion scan or CTPA, or if you do an echo, there's an acute right ventricular strain, please thrombolyze. There are lots of data that thrombolysis is not contraindicated and it can increase the minor bleeding, but this is safe to go for thrombolysis. Or you can go for catheter-induced embolectomy or local thrombolysis. Put the catheter close to the clot, and local thrombolysis is very helpful as well. My fifth case is 32 weeks pregnant lady with jaundice and primary abdominal pain, nausea, vomiting, headache, jaundice, no itching. That's very important. No history of jaundice before, no blood transfusion, not on any medication which can cause jaundice, no travel abroad recently, and there was an antenatal checkup and hepatitis and HIV seronegative. Now, pregnant lady with jaundice and patients, no hepatosplenomegaly, urine protein was double class, so hemoglobin, high bilirubin, high AST. Now, if you see abnormal LFT in pregnancy, you must again come into the basic point. That's why they should come to us in the beginning. You must rule out the common conditions like viral hepatitis, gallstone, ascending cholangitis, drug reactions. These are, of course, must be ruled out. And then pregnancy-specific conditions like HELP, AFLB, acute fatty liver or pregnancy, and obstetric cholestasis. Obstetric cholestasis is actually common during term, and you get itching of the term and so this patient did not have that, and the bile salt level was normal as well. So, talking about acute fatty liver or pregnancy, you get it in 1 in 20,000 cases. Case fatality is 1.8%, and it's mostly near term or early postpartum, and 66% will require ITU care, and 18% will go to the liver specialist unit, and very high mortality in acute fatty liver or pregnancy. HELP or acute fatty liver is sometimes very, very difficult to differentiate, but the HELP is less sick and HELP does not cause liver failure. So a patient is not so unwell, is much more in favor of HELP. Hepatic encephalopathy more common with AFLP, both imaging and biopsy are very helpful. Now, what happened to our patient? We monitored very closely. Then what happened? Initially, platelet count was normal, but later on, platelet count dropped. AST remained stable, and we managed hypertension. This patient has had preeclamptic toxemia, so we managed hypertension with labetalol. And then the discussion went on between obstetrician and patient that when somebody has got this preeclamptic toxemia with HELP, then better to be delivered after 34 weeks. The patient decided not to deliver on 34 weeks, so we observed the patient a normal delivery at 37 weeks and normal LFT after 24 hours of delivery, so it's very, but normal management plan is you must deliver them at 34 weeks. And you can give dexamethasone for lung maturation, and patient was in fact given dexamethasone for lung maturation of the baby. So final diagnosis is preeclampsia with HELP. Now, the conclusion that acute medical problems in pregnancy are not uncommon. You are all going to deal with this. Early recognition is crucial. Tachycardia and tachypnea not physiological in pregnant mothers. Most investigations are safe. And if you have got any confusion, involve your radiologist. Do not forget to speak to your mother, to speak to the patient, your mother. She's very worried, so speak to the patient. SVT in pregnancy, adenosine and DC cardioversion is safe. You can use metoprolol. And cardiac arrest in pregnancy, always making sure the patient to the left lateral tilt, and remember 5 minutes rule. That if patient, you do not get the output back within 4 minutes, you have to take the baby out within 5 minutes. Metabolic acidosis, do not forget fasting ketosis in pregnancy. This is not uncommon. Suspected PE, always follow the guideline, do Doppler of the legs first. Then if you have got any facility for perfusion scan, do the perfusion scan. If not available, go for CTPA. jaundice in pregnancy could be fatal. And always remember, involve obstetric team early. Thank you very much.
Thank you. I think the questions will be at the end of the talk. Dr. Charles. And Dr. Aaron Chowdhury is going to talk about unwell patients who are on the busy front line. Dr. Chowdhury, please. Thank you very much.
Thank you so much. Now I'm going to talk about unwell patients on the basic front line. Now just to explain what the basic front line is, I work in acute medical unit of Langworth Hospital. Let's discuss a little bit about our model, what exactly we do. We are different from accident and emergency because you only look after medically unwell patients. We do get around 16,000 admissions per year. We have got 40 beds. We have got an ambulatory area for patients who really don't require a bed, for patients like TIA, anemia, pulmonary embolism, stable and stable pneumonia. We see those patients in the ambulatory area. We have got a 6 high dependency unit beds for level 2 care. Patients with single organ failure, we transfer them to medical high dependency unit. We do have 12 beds in our source area because when there is any diagnostic dilemma or patient needs to stay for 72 hours in hospital, we keep them in source ward. And the service is delivered by trained acute medicine consultants, and there is a consultant's presence from 8 a.m. to 10 p.m. on weekdays and 8 a.m. to 6 p.m. in the weekends, and it's led by acute medicine consultant. And at night, usually led by medical registrar with a consultant on call from home. Now, this is a beautiful Scotland, and here we are in Dundee. And this is Dundee by the side of River Tay, and this is our hospital, 9 Wells. And this is our acute medical unit. This is the entrance. This is very busy lunchtime. And after lunch, you can see very quiet. This is the ambulatory area where we keep the patient, the stay here. They don't need a bed. Sorry, it's not working. Okay. Now, acute medical unit, our focus is that we actually do triage on arrival, and the nursing colleagues, they do score, or might mention that the national RD warning score, but we have got a Scottish RD warning score that we get all the temperature, blood pressure, respiratory rate, and that is done by nursing team and followed by very urgent medical assessment by registrar and consultant. We identify sick patients early, and of course our main focus is sepsis management by sepsis 6, that means oxygen, blood culture, lactate, antibiotic, fluid and urine output. Most important is antibiotic within 1 hour. We identify organ failure early, and severe sepsis and patients with single organ failure, we manage them in medical high dependency unit. There is a identification problem of the patients who require non-invasive ventilation. This is not the focus. If somebody needs non-invasive ventilation like BPAP or CPAP, we identify them early and start early. This is very important to do that. We closely monitor our unwell patients. There is a strong focus on quality and safety of care by effective team working. And we start our day at 8 o'clock with safety briefing, all the consultants, registrar, junior doctors, nurses, pharmacists, all in a room. The whole idea is, what can you learn from yesterday to make your today better and safer? So it's a very important exercise you should all do. How can I improve my practice today, learning from yesterday? It's a very busy unit, and we can have cases with difficult diagnostic and management issues. So of course we manage severe sepsis. Sepsis are not not going to discuss all those cases. I'm going to discuss a few cases of difficult diagnostic and management issues. My first case is the 54-year-old gentleman admitted with headache. Headache was gradual onset and also complained of generalized weakness and developed aphasia. No history of hypertension, diabetes mellitus, hyperlipidemia, urinary heart disease, non-smoker. Drinks alcohol 20 units per week, no head injury. Examination, no cranial nerve palsy, power in all 4 limbs 3/5, bilateral plantar outflowing, bilateral papilledema. Had arterial CT brain, and that's the CT brain is a non-contrast, and we detected that radiologist, of course, detected that dense clot into the superior sagittal sinus. And again, post-contrast, you can see the empty delta sign, which is very classical for superior sagittal sinus thrombosis. Now, CT venography reported that extensive dural sinus thrombosis with involvement of the deep veins, including the transverse veins, and also extending into the internal jugular vein. So the patient was treated with low molecular heparin for 2 weeks, followed by warfarin for 12 months. This is very unprovoked in a 54-year-old gentleman. So we screened for thrombophilia, that was negative, and also screened for malignancy with PET scan, that was of course negative. Let's talk about central venous sinus thrombosis incidence. We see around 4 or 5 cases per year, and so incidence in 1 in 100,000. So our population 450,000 in Teesside, and it's more common in women, and because especially when women are taking oral contraceptive during pregnancy and puerperium, there's a more risk of having central venous sinus thrombosis. The other common factors are thrombophilic states, malignancy, infection, head injury. The thrombophilia screening that we do check antithrombin, protein C, protein S level, factor V Leiden mutation, G22108 thrombin gene mutation, and hyperhomocystinemia, because there is a controversy about whether high homocysteine is associated with any deep central venous sinus thrombosis. We have to remember in 13% cases we do not find any cause, but again those patients must be followed up, because some of them might turn out to be malignancy after even 6 months or 1 year, so it's very important to follow them up. Next patient is a 45-year-old lady. She is admitted with left upper limb weakness and the dribbling from left corner of the mouth, pins and needles on the left side of the face. On admission, feeling normal. No history of hypertension again, hyperlipidemia, diabetes, non-smoker, social amount of alcohol consumption. Neurological examination on admission was completely normal, but she had symptoms on the left side. Blood tests all normal, lipids normal, ECG sinus rhythm diagnosis very cryptogenic transient ischemic tag. So we had an MRI DWI, and that showed that an infarct in the posterior limb of the right internal capsule. Again, she had CT angiogram, intracranial and arch of the aorta to look for any sort of source of embolus. There was no intracranial stenosis. Cavity Doppler was normal. Thrombophilia study, everything was normal except mild low antithrombin level, 64. The normal value is 83 to 128. She underwent bowel contrast echo, and that showed very thin, mild interarterial septum with a small PFO, peripheral in the valve. Also had, because of the antithrombin level low and then small PFO, so paradoxical embolus was suspected and underwent a bilateral venous Doppler of the legs. There was no clot. So she was then discharged with aspirin, clopidogrel, ramipril, and atorvastatin, and she's currently waiting for transesophageal echocardiography for better delineation of PFO. Talking about PFO, is that 25 to 30% of population we do have PFO. Now management with paradoxical embolus, when patient presents with this paradoxical embolus, so then options are antiplatelets, anticoagulation, or closure of the PFO. There are 3 main trials on this, and the closure 1, PC trial, and respect trial. But again, all those trials did not reveal any optimal treatment. It's not yet established. And the best available evidence has not proven that PFO closure is better than medical therapy. So currently, what closure 1 trial used aspirin clopidogrel for 6 months, followed by aspirin. So a lot of clinicians, stroke physicians, they follow that guideline. Anticoagulation is certainly very useful if somebody is having recurrent cryptogenic stroke or unprovoked DVT with stroke, or indeed somebody has got thrombophilic state. Sometimes you can consider the closure of the PFO if there's a recurrent stroke in spite of patient is on anticoagulation or any contraindication for anticoagulation. And this patient particularly waiting for another antithrombin measurement and referred to the vascular team, and if antithrombin level remains low, then possibly we'll consider for lifelong anticoagulation. The next patient, 42-year-old lady, admitted with bilateral arm pain and central chest tightness while playing with children. And amazing, the patient didn't have any autonomic symptoms, never had any history of any risk factors, no smoker, no family history, examination was normal, 12-minute ECG showed only sinus bradycardia. Troponin I was absolutely huge at 15. And the initial diagnosis was made that non-ST segment elevation MI. She underwent urgent coronary angiography that showed normal coronary arteries but showed some apical lateral hypokinesia, and the comments made by cardiologists were possible embolic cause of MI. Thrombophilic ischemia was negative, had a TOE, transesophageal echo, that showed large tunnel patent forming valve, no thrombus in left atrium or left atrial appendage. Again, patent for we just found those 2 cases within last 6 months, I thought to share with you. And again, management was done by the cardiology team as because there is no evidence of closure because it's the first episode, aspirin, clopidogrel, atorvastatin, and ramipril. And she's under regular follow-up with our cardiology team. Next patient is a 66-year-old lady admitted with headache, pyrexia, visual disturbances, and profound vomiting. She had 3 months history of vague constitutional symptoms with mild headache, poor appetite, and she was not very sure whether she has lost some weight. History of previous TIA on clopidogrel, perindopril, and simvastatin. Temperature was 37.8 with mild hypotension. Chest, heart, and abdominal examination were normal, neurological examination normal, ophthalmoscopy examination normal. So this patient was admitted overnight, seen by registrar and thought that CNS infection, and had a lumbar puncture with normal pressure, no cells, no xanthocomia, and was given antibiotic, and of course had cover for listeria, according to guideline that it aged more than 55, cover for listeria. Now, the next day ward round, I saw the patient, and it's very striking to me that number one point was that patient had a 3 months history of this all the mild headache, poor appetite, and weight loss, and also patient did not have any photophobia or neck stiffness. And one thing I found is very important that had a bitemporal hemianopia. So I looked into the blood test and said TSH was low. They looked into the free thyroxine level, that was low as well. So I asked for an urgent salts and action test with baseline cortisol 43 with suboptimal rise to 207, urgent MRI, and that showed the pituitary apoplexy. And then we gave steroid, intravenous, thyroid supplementation was given, antibiotic was stopped, and the patient was discharged after 3 days. We planned to follow up by neurosurgical team and endocrine joint care. So please remember that they can present like meningitis, pituitary apoplexy. Now the next patient is 52-year-old gentleman admitted with dizziness, weakness, alert, heart rate was 40 per minute, blood pressure 70 by 45, respiratory rate normal, saturation normal, 12 ECG showed sinus bradycardia. Patient came to emergency department and he was given atropine 3 mg and 2 liters of intravenous fluid. and was transferred to medical high dependency unit. He had history of ischemic heart disease, hypertension, depression, and also had tachycardia syndrome, for which he was inserted a permanent pacemaker. Medication history, when you rang his wife and say that he takes regular diltiazem 300, so we thought that possible diltiazem overdose, and in fact he took 13 tablets of diltiazem, so 3,900 milligrams of diltiazem. So when I saw in the ICU, patient still hypotensive, still continuing IV fluid, put central line in, arterial line in, CVP was 12, mean arterial pressure was 50. We gave 10 ml, 10% calcium chloride over 10 minutes by central line, and we gave total 3 doses 20 minutes apart. And the pacemaker was reprogrammed at a higher rate, and we did a portable echo that showed global left ventricular systolic impairment with normal left ventricular size. The patient still hypotensive, then we discussed with the National Poison Information Center. What they suggested, okay, try next step is to give IV glucagon, as you give it in beta blocker overdose, but glucagon will only increase your heart rate. It did not do anything with cardiac contractility. So we gave 1.5 IV, then another 1.5 milligram, then there was no change of mean arterial pressure, slight rise of the heart rate. Started then on noradrenaline to achieve a target of MAP 65 millimeter of mercury, and titrated the noradrenaline very quickly. We also started the vitamin, but there was very, very little response with the maximum dose of vasopressor. Patient became agitated, confused, and developed acute kidney injury. Again, discussed with the Poison Information Center, then they suggested there are two options now. Either we can give high-dose insulin dextrose or lipid emulsion therapy, which called intralipid. So they suggested that go for lipid emulsion. So lipid emulsion is the fat used for total parenteral nutrition. So we gave bolus and then infusion through central line for 30 minutes. The mechanism of action is it coats the lipophilic drug like diltiazem, and so that it doesn't get attached to the myocardium. And also the fatty acid, because it's a fatty acid, it works as a ready-made source of energy to the myocardium, with the hope that myocardium will contract better with the fatty acid. And it's a very good result with intralipid infusion. Mean arterial pressure after 30 minutes came back to 65 millimeter of mercury to the urine output, and vasopressor inotropes weaned off over the next 6 hours and discharged after 24 hours. So remember, calcium channel blocker, we are using it so many patients nowadays. It's an overdose. It's not uncommon. It could be life-threatening and high risk of death. The next patient is 40. I'm sorry that I didn't know that Miles mentioned about this particular patient. Not this patient, but the same type of patients. But it raises the point that Dr. Johnston made this morning, that 48-year-old gentleman came with chest pain, no radiation, non-hypertensive, this patient was not seen by myself, I don't know, but whatever written in the note, I investigated as a clinical lead. The patient examination was normal, ECG normal, chest X normal, troponin I normal. Seen by consultant cardiologist, impression was non-cardiac chest pain, no further cardiac investigation. Patient did have ongoing chest discomfort, seen by medical registrar called gastroesophageal reflux disease, went home and found dead. That's bedroom next morning, postmortem showed type A dissection of the aorta. Again, the learning point, what we raised, that if patient comes to hospital with chest pain, we cannot discharge the patient with chest pain because we need to have a working diagnosis. We need to relieve the symptoms as well. So again, observe this patient is very, very important. Now, next patient is an 18-year-old boy, 4 weeks history of headache, gradual onset, 3 days prior to his admission into our hospital, admitted to another hospital with headache, myalgia, greenish nasal discharge. CT brain then showed opacification of sinuses, was treated as frontal sinusitis, headache persisted, got worse 4 days prior to this admission. Current admission, severe headache, vomiting, became drowsy and confused, and also developed a right leg weakness over the last 24 hours. temperature 38.2 degrees Celsius, or on the right leg 1/5, breast reflexes, plantar outgoing, normal fundoscopy examination. IV antibiotic was given within 1 hour, of course, and then fluid and had an urgent CT and sinuses. And it showed the extensive opacification of the frontal, maxillary, sphenoid, and ethmoidal sinuses. Then the clinical suspicion was, okay, is he having some meningitis or encephalitis? So we went for a lumbar puncture. It showed predominant lymphocyte, and we thought could it be viral. The viral PCR came out to be negative. And then after 12 hours, patient was still drowsy. Then we went for urgent MRI here, and that's the MRI scan, and that showed subdural empyema, left subdural empyema. So just to show that it's here in that region, the subdural empyema. So they had urgent neurosurgical evacuation through the left parasagittal craniotomy. I also had endoscopy, drainage of sinuses, and then following operation, he had one episode of right-sided focal seizures on the second post-operative day. Bus culture grew the Streptococcus pylori and had prolonged antibiotics for 6 weeks, kept Tiazole, and the right leg weakness completely resolved after 2 weeks. Follow-up after 3 months, back to normal, no further seizures. 84-year-old lady presented with central chest pain, breathlessness, dizziness, had a biological aortic valve replacement 1 month back for severe aortic stenosis, also had history of peripheral vascular disease, examination was normal, ECG showed anterolateral ST depression, chest X-ray showed cardiomegaly, troponin I was 7.5, was high, was treated as acute coronary syndrome with aspirin, clopidogrel, fondaparinux. Fondaparinux is a synthetic pentasaccharide anti-10 inhibitor, and bisoprolol. Coronary angiography showed 70% stenosis of LAD, for which she had drug-eluting stent. The 4 days after admission, then she suddenly developed a sudden back pain, loss of sensation and weakness of both the legs, felt breathless as well at the same time. Examination, pulses are absent, both feet were cold and mottled, and she had an urgent CT angiogram of aorta, and that showed there is actually the contrast not coming down at all. This is the contrast there, nothing coming down. It's a complete occlusion of the abdominal aorta. Now, there are a few pictures. This is the cross section. You can see that this is the aorta. Then going down the bifurcation, you can see that all block, and there's a clot there. And this is the pulmonary arteries. There's a clot sitting over there, so that's why she was breathless. So extensive thrombus into the arterial and pulmonary artery territory. So very unwell. So the diagnosis was actually heparin-induced thrombocytopenia and thrombocytosis hit, and the patient received heparin during coronary angiography. And also, patient was on fondaparinux. There are case reports that fondaparinux itself can cause hit, heparin-induced thrombocytopenia. So, just let me talk about HATE. It's a life-threatening complication to exposure to heparin. A few case reports on fondaparinux, and heparin means both unfractionated and low molecular heparin. Reaction 10 times less with low molecular heparin. It occurs up to 5% patient exposed to heparin and low molecular heparin. And it can happen regardless of the dose, schedule, or route of administration. And the mechanism of action is that it develops autoantibody against the endogenous platelet factor 4 in complex with heparin, and then it activates platelet and produces enormous thrombosis into the system. And you develop thrombocytopenia, but bleeding is uncommon. And usually occurs 5 to 10 days after initiation of heparin. Diagnosis is mainly clinical. You can check HIT antibody, and mortality is as high as 20%. Our patient, as I say, had coronary angiography, had heparin flush, and also had fondaparinux, and so diagnosis was suspected as HIT. Patient passed away, unfortunately, after 1 hour. So, in conclusion, the unwell patients on the front line of hospital that we need to remember that cerebral venous sinus thrombosis can easily be missed, and we should always look for underlying diagnosis. We should follow them up for look for malignancy and hemophilic state. Patent foramen ovale can cause stroke and acute myocardial infarction, but there is no strong evidence until now that closure of the patent foramen ovale has got any advantage over medical therapy. So current treatment is still medical therapy. Headache, visual disturbance, hypotension, and think about pituitary apoplexy. And also, please, whenever you get a patient of headache, always look for visual acuity and field of vision examination. Not done all the time, so it's very important to do that. Refractory hypotension with bradycardia, think about calcium channel blocker overdose, and think about that all the treatment that we mentioned about that, especially intralipid infusion. If somebody is getting ongoing chest pain, observe and investigate further. Dissection of the aorta is underdiagnosed. So please monitor them and also get CT angiogram if you suspect it. Persistent headache with sinusitis. Yes, sinusitis is common. We give them antibiotic, but if there is a persistent headache, and you please go for CT. But if CT is negative, then please go for MRI, because CT may not get the diagnosis of subdural empyema all the time. Patients on heparin, even on fondaparinux, monitor the platelets, consider heat if platelet count drops, and please stop the heparin immediately. Consider alternate anticoagulant. And so it's very important. Fondaparinux can cause heat. This is very important to remember. So in conclusion, that is one thing I would advise to my junior colleagues, that please observe the unwell patient who you can't reach a diagnosis. Examine in details and examine all the results and interpret it correctly and discuss with your colleagues. Thank you very much.